Thank you everyone for joining us today for a special event titled Mental Health in a Global Pandemic, Lessons Learned from Psychological Science. This event is part of the APS Global Collaboration on COVID-19, which is bringing together psychological scientists to understand how our field has been applied to combat the pandemic, discuss how it hasn't been used, but perhaps should have been, and identify gaps in our knowledge and future avenues for research so that society is better equipped to handle future health crises. My name is Andy DeSoto. I'm the Director of Government Relations at Association for Psychological Science. And if you aren't familiar with APS, we are an international organization of psychological scientists and students who are dedicated to advancing research psychology for the benefit of science and society. We're so pleased to have you here today. We have a mix of APS members here and folks who aren't members of us yet, so please do consider joining APS for access to other events like this and much more. Before I pass the microphone over, just a couple of quick logistical details. Today's webinar will be 60 minutes in length, and as attendees, your cameras and microphones will be off for the session. We encourage you to make use of the question and answer box at the bottom of your screen to submit your questions to the panelists, or make use of the chat function to catch up with one another in the group, which I see folks are already doing. That's wonderful. Today's event will be recorded and a video will be made available following the presentation. So with that, I will turn it over to Dr. Allison Harvey, who is the leader of the APS Collaboration's working group on mental health and COVID-19. Dr. Harvey, please take it away.
Thank you, Dr. DeSoto, and good morning and welcome. My name's Allison Harvey. I'm a professor and clinical psychologist at the University of California, Berkeley, and I am serving as the moderator for our webinar today. As we begin, I invite you to get into focus the far-reaching scope of this pandemic. According to the World Health Organization website on Tuesday, since the beginning of the pandemic globally, there have been 265 million people who have tested positive for COVID-19, and 5.2 million people have lost their lives to COVID-19. While this pandemic has upended the lives of every single one of us, it is also very clear that it has unequally impacted Black and Indigenous people, people of color, and people who are marginalized. Further, the pandemic has exposed and exacerbated deep inequalities. Today, we're going to consider the mental health ramifications of the pandemic and highlight some of the lessons learned from psychological science. To do this, we're going to hear from 4 expert psychological scientists who will each share some of their work on COVID-19 and its effects on mental health and illness. In order of presentations, our speakers are Dr. June Gruber from the University of Colorado Boulder, Dr. Derek Novacek from the University of California, Los Angeles, Dr. Christopher Bean from the University of Southern California, and Dr. Sherry Stewart from Dalhousie University. Without further ado, I will hand over to Dr. June Gruber. Thank you, June.
Thank you for the kind introduction. I'm humbled to get us started today. And my talk will be really focusing on a call to action with clinical science and mental health in the time of COVID. As was very astutely pointed out, COVID is indeed a unique, compounding, and multidimensional stressor that has already precipitated huge increases in mental health challenges. Given this, our field must assert a leadership role in understanding and addressing these challenges during and enduring beyond COVID. What I'll do today with this roadmap is outline 3 key points I hope to touch on in my brief talk. First, I'll share some background behind a recent field-wide call to action in this domain. Second, I'll highlight some critical and emerging mental health themes about what we're learning about the ways COVID has impacted our mental health and how sometimes it's not exactly what we expected it to look like. Third, I'll point to a path forward highlighting important priorities for the future. So I'll start with this first call to action. This was something that in our field, we felt we must tackle because what we saw is that COVID was a unique, multi-dimensional and significant impact on mental health and illness. And there's three ways in which it really caught our attention in this way. First, it's a stressor of extremely high stakes, long-term or chronic stress with a lot of uncertainty baked in and causing significant disruption to daily routines and resources. Second, it's a widespread stressor impacting multiple levels of society and multiple systems at individual, social, and political levels. And finally, and perhaps most tragically, vulnerability to mental health challenges was illuminated, in part because many of the safeguards as a human species we often have to buffer against stress were, ironically, in some ways dampened or blocked due to social distancing and earlier stay-at-home mandates. And indeed, as Mitch Prinstein, the APH Chief Science Officer, Professor of Clinical Psychology, a colleague to many of us, said, if psychologists were asked to create the conditions that would be most stressful, increasing the risk for mental health challenges among the greatest number of people, it would probably look a whole lot like what we're experiencing now. So during this time, Mitch and I enlisted a call to action, in fact, on Science Twitter, literally asking our colleagues over this social media platform if they'd like to join together with us. Within literally a matter of days, I think 3 to be exact, we had rallied an authorship team spanning 37 clinical psychologists across the country and putting a paper together in 3 weeks in which we tried to summarize the challenges, opportunities, and call to action, focusing on mental health and clinical psych during the time of COVID. So what have we learned? This is where I'll turn to these emerging themes about mental health to think about what we have learned and what we're continuing to learn from COVID. This work spans work from my lab that I'll mention, as well as some of my colleagues who are interdisciplinary clinical scientists who've granted me permission to share a few highlights from their innovative approaches as well, to better consider mechanisms and trajectories of psychological disturbance. First, the theme that I think to me has stood out in many ways as one of the most significant themes is the critical role of context. We cannot make global generalizations about how mental health impacts individuals or even certain subgroups of individuals. We need to carefully look at nuanced context, because what we're seeing is that in many ways is telling us a lot about the trajectories of mental health and clinical symptoms. And I'll give you first an example from my lab. This is a study on emerging adults and mental health during their transition to college. This is what we call our Emerge project. And these are some of my collaborators I want to just note. During the study, we had a longitudinal monitoring period before COVID, fall 2019, and during what we call the initial COVID outbreak in spring 2020. We sampled mood and anxiety symptoms using the DSM-5 cross-cutting measure, and we created an index from our colleague Aaliyah Crum of COVID risk. This contained 7 questions, yes or no, asking if people had been diagnosed with COVID, hospitalized, quarantined, been in a high-risk area, kind of assessing the extent to which COVID impacted them, if they were truly at risk for the virus itself. When we looked at the data for depression and anxiety, initially, what we found looking across everyone pre-COVID to that COVID outbreak is that depression didn't seem to change over time across everyone. This initially surprised us, as I imagine it would many, but in fact, when we looked under the surface and partitioned individuals into high and low COVID risk impact groups, we saw a significant increase in depression, but only for high COVID risk participants, so those who had indeed endorsed having a lot of direct exposure or risk to the COVID virus itself. We did not see any significant change, however, for those who were low risk. When we looked at anxiety, we saw across everyone this surprising decrease, a small decrease in anxiety. But once again, when we considered context further, in this case, kind of pandemic risk context, anxiety itself was moderated by COVID risk, showing a significant decrease in anxiety only for those low-risk participants, perhaps those who had not been impacted by the virus and in some way found maybe some of the change in their daily routines to be a way, a sort of a stress relief. For other participants in this study, we did not see changes in anxiety slides. So context really matters in terms of COVID impact. Likewise, my colleague Eiko Fried did a fantastic study, an intensive longitudinal study of COVID onset in the Netherlands during the initial outbreak. And what he found in this way, when we look at mental health of university students, that the context here of when we ask individuals about their mental health was essential. And in fact, he found elevated levels of depression, anxiety, and stress really tied to or contingent upon different events that were impacting university student mental health. Universities closing, disruption in their daily routines and rhythms, again, suggesting context matters, how much COVID impacts individuals, and exactly what's the context of what's happening in their life when we're asking about mental health. So context matters. At the same time, resilience is a reality. Resilience also has been happening during COVID. And here what I want to highlight with respect to resilience is some work by George Bonanno and others. In this study, they sampled about 800 adults longitudinally 3 times between May and October 2020. And what they demonstrated was that many individuals during this time period showed resilience, both in anxiety symptoms, with over 62% showing resilience trajectories in anxiety, as well as depression. So at least it seems during this kind of initial period of COVID, there was a significant amount of resilience among many or most individuals. But does this continue to persist when we think about the timing, or what I think of as the long haul when it comes to mental health in COVID? And here timing is critical, and we must expand our aperture or our time window when we're considering looking at what COVID does to our mental health, considering both more acute or initial impacts, which is the majority of what we've talked about so far, versus these more chronic or enduring impacts. Turning again to some of the data from my team, we had a subset of our students from University of Colorado Boulder and University of British Columbia do a time 3. This is fall 2020, so a full year later from their initial pre-COVID baseline. And we saw our results start to look a little bit different. Depression, for example, no longer only impacted or worsened among those at high risk of COVID, but in fact, here we began to see more general linear increases over time in depression. In our earlier data, we saw no changes in life satisfaction from time 1 to time 2. But as we got further along into time 3, we start to see a quadratic function showing that there may be also some reductions in life satisfaction over the long haul. This again suggests that we may need to be considering more of a long haul impact of chronic stress when it comes to mental health. And in such cases, it may be much more challenging to remain resilient over extended periods of time. Likewise, my colleague Rick Zimbarg and Robin Nussloch at Northwestern also were finding in their really fascinating longitudinal symptom trajectory modeling over time, unique kinds of changes in distress, anhedonia, and fear. For example, with respect to fear, what they found is there was a small initial uptick in fear during the initial COVID onset. But when they looked over these longer periods of time, up to 40 months later, during what they call a COVID maintenance period, they then saw a much more significant or large increase in fear. That's that orange kind of dashed line there. Likewise, seeing unique trajectories for anhedonia and general distress, again, suggesting time is essential and we need to sort of expand our aperture. And this leads me to highlighting priorities for the future. One of the critical priorities is we need to consider context and timing. This is not a one-size-fits-all story, and that mental health impacts depend on context and is time sensitive. And importantly, we need to consider socioeconomic and racial disparities that Derek Novacek, who will speak next, will go into some of his compelling work along this domain. Likewise, it's our responsibility, and why I'm so grateful to be part of this panel today, to engage psychological scientists in a more public-facing way. We have the power and opportunity to normalize and destigmatize mental illness during COVID, and those lessons I hope carry us well beyond this pandemic. And we have an obligation to disseminate science as well as services to those most in need. So with that, I'll just briefly touch on and segue to Derek's wonderful talk. first highlighting some work from my colleague April Thames, also at UCLA, and her initial work also finding the importance of disparities in impacting mental health outcomes. Her work in particular documents racial disparities in self-reported pandemic-related stress and markers of inflammation among African-American adults compared to non-Hispanic white adults. Again, this is a key area we must give greater attention to. And with that, I turn to Derek Novacek, who's going to share his compelling and important work on racial differences in the psychosocial response to the COVID-19 pandemic in veterans with psychosis or recent homelessness.
Thank you, June. All right. All right. Good morning and good afternoon to everyone, depending on your time zone, or maybe even good evening. As Dr. Gruber said, the title of my presentation is Racial Differences and the Psychosocial Response to the COVID-19 Pandemic in Veterans with Psychosis or Recent Homelessness. And I'm a postdoctoral research fellow at UCLA in the VA Greater Los Angeles. And so I will be talking about these are data from a longitudinal study that we conducted for over a year with veterans with psychosis or veterans who actually had experienced homelessness and were housed right before the pandemic started. So I'll go ahead and jump in. So there's no greater kind of racial disparity than what we see in homelessness and also with what we see in individuals with psychotic disorders. And so these are two vulnerable populations in which there are pretty great racial disparities. So Black Americans are overrepresented in the homeless and veteran general populations. And Black Americans are also overrepresented among individuals with psychotic disorders. And so there's evidence suggesting that there are elevated rates of psychosis among Black Americans, and among those experiencing homelessness, Black Americans are greatly overrepresented due to systemic racism. And although the COVID-19 pandemic has had an undeniable impact on all of us, the burden and the consequences of the pandemic have not been equal across groups. We might all be in the same storm, but we are all in different ships trying to navigate the storm. So Black Americans, as we all know, have had higher infection and mortality rates due to COVID-19, and this could result in disproportionate mental health consequences. And a recent paper that was published in Clinical Psychological Science showed that these pre-pandemic stressors, likely a result of systemic racism, predicted worse mental and physical health outcomes during the pandemic for Black Americans. So it's kind of compounding stressors made the pandemic even more difficult for many Black Americans. And those experiencing serious mental illness or homelessness also had higher infection and mortality rates during the COVID-19 pandemic. And so this is a group that might be also especially vulnerable to negative consequences of the pandemic. And so as we started our research study back in March 2020, one of the questions that I immediately had was that would our Black veterans who are part of one of these two vulnerable clinical populations have worse psychosocial outcomes during the pandemic compared to white veterans? And now it might be easy to, assume that there would be kind of a disparity because there is a lengthy literature on the double jeopardy hypothesis, which suggests that individuals of multiple marginalized statuses experience worse outcomes compared to those of either a single minoritized or privileged status. And so according to the double jeopardy hypothesis, we might expect to see poor psychosocial outcomes for our vulnerable Black veteran groups. But there's also a robust literature of different protective factors and sources of resilience in Black Americans and in Black communities, with one being social support. And social support has shown to be protective against depression, suicidal ideation, and other forms of psychological distress among Black Americans. And in a recent paper that's currently under review from our research group, we found that Black veterans experiencing homelessness actually had better social integration with family compared to white homeless veterans. And so even while they were experiencing homelessness, they had better connections and quality of contact with their family. And so in line with this social support hypothesis, we're calling it, we might also see better social integration for our vulnerable Black veterans during the COVID-19 pandemic. So this was a remote study of veterans that was conducted through the VA Greater Los Angeles healthcare system. And there are 3 time points that I'm going to be talking about today. So we had a baseline assessment. The study actually started in mid-May with our baseline assessment that ran through mid-August. But we also asked participants to give a retrospective estimate of their pre-COVID functioning in terms of symptoms and community integration. And then we also, I'll be presenting our first follow-up point, which was between mid-August 2020 and October 2020. And so for community integration, we primarily use the role functioning scale, which looks at family integration, social integration with friends, work and productivity, and then independent living and self-care. And then we measured depression through the PHQ-9, anxiety through the GAD-7. Both of these are self-report measures. And then we use the contamination scale from the dimensional obsessive compulsive scale to measure contamination fears as part of an OCD symptom presentation. And so this are the characteristics of our sample. So there weren't any significant differences between the Black and white veterans in age, sex, or education. You can see that across both the Black and white veterans and across the 3 groups, so our recently housed veteran group, our veterans with psychosis, and then our control veteran group who had no history of psychosis or homelessness, they were pretty similar in terms of age, in their early to mid 50s. This was an overwhelmingly male sample, which is typical of many veteran studies. And then education was 1 or 2 years post high school. And there were a little bit of differences in terms of the number of Black and white veterans in each of the groups, but they were relatively the same across. So jumping right into our results, just to kind of orient everybody to the graph. So we ran generalized mixed linear models to examine the effects, to examine racial differences, group differences, and also to look at the effects of time or visit, and then to also look at any interactions. And so on the, so we have our Black veteran groups on the left and our white veteran groups on the right. And then on the x-axis, you can see these groups outlined, control, homeless, and psychosis for both Black and white veteran groups. And then this on the y-axis is our family integration rating. And so you can see that there was a main effect of race. So we actually found that across veteran groups, Black veterans, again, had better family integration than white veterans. And there was also an effective diagnosis. Not surprisingly, the control group had better family integration than the veterans with psychosis or the veterans who were recently homeless. There was also a significant interaction of time by race, and that family integration actually seemed to get better over time from the baseline, from the pre-COVID estimate to the baseline to the follow-up. For the Black veteran group, you can see that that kind of small increase across time, whereas for the white veteran group, it either didn't change or maybe there might have been even a slight drop off. And then for social integration, so this is primarily relationships with friends, there weren't any effects of visit or time. There were no effects of race, so there weren't any significant racial differences, but there was an effect of diagnosis or group, in that the control veteran group, again, had better or higher social integration with friends compared to the veteran homeless and veteran group with psychosis. And then for work and role productivity, again, we saw a main effect of diagnosis or group, and that the control group had the highest levels of work and role productivity, which isn't too surprising, but we did not see any effects of race. There were no effects of time, and then no significant interactions. And then for independent living, we did see an effect of time, and that independent living seemed to increase over time from the initial to the baseline assessment. And this primarily seems to be driven by the recently homeless veteran group, which is why there was also a significant interaction of time by diagnosis, and also why there was a main effect of diagnosis, in that the main effect of diagnosis actually was that the control group was slightly higher in terms of independent living than the other two groups. But you can see for the interaction, if you look at the homeless veteran groups for both Black and white veterans, their independent living, there's a slight increase from the pre-COVID to the initial baseline assessment to our first follow-up. So when we looked at these results, we were a little surprised that we didn't really see too many racial differences. We were also surprised that we didn't really see too many changes with time across the pandemic. It seems like that functioning and community integration were relatively the same throughout the pandemic for most of our veterans. But then when we looked at psychiatric symptoms, we saw a little bit different of a pattern. So we did see a main effect of time, so that at baseline, that was the highest or the greatest amount of depression that was reported by our veterans, particularly in our homeless veteran group, which is why there was a significant interaction of diagnosis and time. The homeless veteran group seemed to be increasing more in their self-reported depression compared to the control and psychosis groups. You can see across all groups, for the most part, there was a pretty big increase in depressive symptoms from the pre-COVID estimate, which was January 2020, to the baseline initial assessment, which was in May. And then it seemed like people kind of rebounded for the most part by the follow-up visit, which was late summer and early fall. We again saw a pretty similar pattern for anxiety, with there being a significant effect of time, with anxiety being the highest at the baseline assessment or the initial assessment, and then with kind of a rebound during the follow-up visit. And there was also a main effect, or sorry, a significant effect of diagnosis with the homeless veteran group having the highest levels of anxiety. And then for contamination fears, again, we saw a main effect of time. So there was a big increase in OCD symptoms and contamination fears from before the pandemic to our first baseline assessment across groups. There was also actually a significant effect of race. So Black veterans actually reported more contamination fears than white veterans. And then you can see there was a slight drop off in contamination fears to the baseline assessment, or sorry, during the follow-up assessment, but still significantly higher than the pre-COVID estimate. So contamination fears came down a little bit, but not as much as depression and anxiety did across the clinical groups and across both the Black and white veteran groups. So kind of in summary, there were few racial differences in our study that suggested our findings weren't consistent with the double jeopardy hypothesis, and that Black veterans experiencing homelessness or with psychosis would have worse psychosocial outcomes. We did see, again, this pattern of better family integration for Black veterans across groups. And this is consistent with another study that we did that was data several years before the pandemic. So it's interesting to find a similar pattern of findings. And then we also saw that Black veterans had more contamination fears compared to white veterans. And this is consistent with findings prior to the COVID-19 pandemic. There's some really interesting data on contamination fears among Black Americans and how it relates to the legacy of Jim Crow and the separation of Black and white people in the US in terms of drinking fountains and bathrooms. And so there's this idea that maybe Black Americans have overcompensated for this legacy of Jim Crow in terms of having higher cleanliness standards because of the misrepresentation and the racist tropes about Black people being dirty and contaminated. Also for time or visit, it seemed to matter most for symptoms, for depression, anxiety, and OCD symptoms, but didn't really seem to matter very much for community integration or functioning. So why weren't there racial disparities? Well, it's possible that there were protective factors for our Black veteran groups, including higher levels of collectivism and communalism that maybe protected Black veterans from experiencing some of the consequences of the pandemic that we might see. And again, this is consistent with prior findings from our research group. There's also another study that was done in the 90s that found that Black veterans experiencing homelessness reported more social contacts compared to white veterans. It's also possible that the VA's wraparound services are mitigating potential racial disparities that we might see otherwise. So all of these veterans are enrolled in the VA and have access to case management, psychotherapy, psychiatric symptoms, housing vouchers, and rental assistance. And interestingly, in line with this, although we know that Black and Hispanic populations have higher COVID infection mortality rates just in the general population, they also Black and Hispanic veterans have higher COVID infection rates compared to white veterans, but there actually is not a difference in mortality rates. So Black and Hispanic veterans are not more likely to die from COVID-19 as we see in non-veteran populations, and that might be a result of having access to care through the VA. So I would just like to acknowledge all my collaborators and funding sources, and I'm happy to take any questions before we move on to our next presenter. All right, well, I will go ahead and introduce Dr. Christopher Beam from the University of Southern California.
Thank you, Dr. Novacek. Okay, as Dr. Novacek had mentioned, my name is Christopher Beam, and today I'm going to give a presentation on age and gender differences in anxiety, depression, and loneliness during the COVID-19 pandemic. From the outset, I'd like to thank my research assistant, Ryan Moschtel, for helping out with this research, as well as the Alzheimer's Association for laying the foundation for this work, in part because this extends from a larger project in which we were investigating the effects of change in loneliness in older adults on dementia risk and cognitive decline in older adults. And as part of that work, we found that there wasn't much change in loneliness in older adults, but quite a bit of change in trajectories of loneliness among younger adults. We really didn't think much of those data at the time. That is until March 15th, 2020, when the state of California issued its shelter-in-place order across the state, at which point we began to think about how important these differences may actually be between older adults and younger adults. And this work we published, suggesting that the psychological sequela of social isolation may be worse for young adults than older adults. And this is in part based on data that we presented from the Health and Retirement Study, showing here that loneliness scores across the age range from 20 to 100 is by far more dynamic for millennials, for younger adults, than it was for any of the other groups, for Gen X, baby boomer generations, and the silent generation. And sure enough, in a JAMA report that came out 8 months after the start of the pandemic, at least the start of the pandemic in the United States, they opined that older adults were not as negatively affected as thought, corroborating our prediction to some degree. And so this has led us to ask the question, well, we know the pandemic has affected many, so boom. And that has sent us down a deep rabbit hole of actually archiving loneliness, anxiety, and depression literature across age and gender during the time of COVID. So we are mining Web of Science and recording statistically significant gender and age differences in data collected post-pandemic, that is after the shelter-in-place orders, in order to evaluate whether women or men, or neither, are more affected by the pandemic, and whether younger adults, into our prediction, are more affected by the pandemic than older adults. So what I'm going to present today are some preliminary findings giving the overall results. And then this is a global pandemic, so I'm going to present heat maps showing the percentage of statistically significant findings also by country, again, in those that we've collected so far. I will also say, and this actually came up in the Q&A a little bit ago, we are indexing effect sizes. I'm not going to talk too much about them, in large part because the average effect sizes, as both Dr. Gruber and the questioner indicated, are rather small. These effects tend to be Cohen's d effects of 0.2 to Cohen's d effects of about 0.4-ish. Let's go back. Some general characteristics of the studies that we have archived up to this point. We've archived 49 studies for loneliness, 100 for anxiety, and 120 for depression across numerous countries, a sampling here in the West, United States, Canada, in the East, China, and in South America, Brazil, with the United Kingdom, Ireland, Germany, Netherlands, Norway, Australia, Russia, India, among others that we'll be presenting on. The populations that we're focusing on in this review are community populations, healthcare workers, COVID-19 patients and survivors, as well as students and educators in secondary educational settings, as well as university settings. We are confining the age range to be 16 plus years, and we are indexing significance tests. There are multiple per study. For loneliness, we have 46 for age, 65 for gender. For anxiety, we have 74 for age and 108 for gender. For depression, we have 112 for age and 126 for gender, for which we'll be presenting. Okay, so for loneliness, out of the 46 significance tests that have been performed, about 17.5% of them have observed that older adults reported worse loneliness than younger adults. Again, corroborating what Vihia reported, that older adults have actually fared okay on average, or at least at the population level, compared to younger adults. And we see that in the heat maps here. So what you're looking at is the percentage of significant hits by country from 0 to 1. So yellow will indicate that no studies observed that older adults were worse off than younger adults, at least in terms of their loneliness. And red will indicate that all studies we've collected collected for that country suggest that older adults are worse off than younger adults. And the pattern is pretty clear. Other than Brazil and China, we're seeing that older adults are not faring worse than younger adults. The flip side of this is that this could be either a null effect, or it's that younger adults are actually faring worse than older adults, which is what we're seeing, at least in terms of loneliness. For gender differences in loneliness, of the 65 tests that were performed, 72% found that females were faring worse than their male counterparts. This is a departure from non-pandemic collected data. There's a very nice study out of the Netherlands indicating that there are few to no differences between men and women. So we are seeing the globe over a significant difference between men and women. So women are reporting more severe feelings of loneliness and social isolation compared to men, particularly in the West, Central and Northern Europe, as well as Brazil. Okay, in terms of anxiety, of the 74 significance tests that we've collected so far, 20% of those studies suggest that older adults are reporting more significant symptoms of anxiety or anxiety-related disorders compared to younger adults. When we look by country, we tend to see that the globe over, this pattern holds, except for equatorial countries like Mexico, Nigeria, and Ethiopia. And that is consistent with non-pandemic collected data as well, that older adults typically report fewer symptoms of anxiety than younger adults on average. In terms of gender differences, we see a fairly clear finding here that women are more likely to report symptoms of anxiety and anxiety-related disorders than their male counterparts, and this appears to hold the globe over. In terms of depression and depressive symptomatology, what we find is that of the 112 significance tests that we've archived, about 16% of those studies report that older adults have more severe symptoms of depression or depression-related disorders than younger adults. And then when we look by country, looking by country, we see that it generally holds that older adults are not faring worse in terms of their depressive symptomatology than younger adults. That too is consistent with non-pandemic collected data, although this is somewhat contested, as symptomatology tends to increase in older adults, whereas diagnoses tend to decline with age. In terms of gender differences, of the 126 tests that were performed, about 55% suggested that women reported greater symptoms of depression than their male counterparts. Typically in non-pandemic times, we find that women are diagnosed with depression at a rate 2 times that of men. So we would have expected, if pandemic data held compared to non-pandemic data, that by country and overall, that there would have been a higher rate of statistically significant differences between men and women. So we are seeing some leveling of the playing field, perhaps, between depressive symptoms and depression-related disorders between men and women. Okay, so a couple of implications here. I think that he is generally correct, at least at the population level. Older adults really have been more resilient during the pandemic than anticipated. And I think about some of the work that we do out of the Department of Family Medicine here at the University of Southern California through the Geriatric Workforce Enhancement Program. We had an age-friendly student-senior connection program where the young adults thought they were helping the older adults and the older adults thought they were helping the younger adults. So I think there's some compelling evidence that older adults really have fared okay on average during the pandemic. Finally, with the increase in loneliness among female populations and the leveling of the differences between men and women in terms of their depressive symptomatology and depression-related disorders, I think it's time to employ some active coping strategies that can make people's lives a bit more rewarding. I realize that this can be tough depending on social distancing requirements in your country or in your state, but rather than more passive coping strategies such as drinking and substance use that we'll hear about here in a moment, coping strategies that tackle day-to-day activities and general activities that people tended to enjoy prior to the pandemic can be used to tackle feelings of loneliness and social isolation. And with that, I will go ahead and conclude and pass the baton to Dr. Sherry Stewart from Dalhousie University, where she will be giving a talk entitled No Exit, Couples Distress and Substance Use During Lockdown. Thank you for your time and attention.
Okay, thank you very much, Dr. Bean. So I just want to thank the APS for organizing this and giving me a chance to present on the work that we've been doing on romantic couples and how they're coping and in relation to their substance use during lockdown during the COVID-19 pandemic. So I'm going to be presenting on 3 studies, all from a single data collection. So the first will focus on when I'm talking about homeschooling. So here, this is the label I'm giving to virtual learning when parents, when schools were closed down as a public health measure and parents were assisting their children either in virtual learning and supervising them or in providing instruction themselves and how that relates to substance use. A second study on how homeschooling and alcohol use are related and how that varies by gender. And then I'm going to switch gears from homeschooling to looking at couples conflict and how that's related to their alcohol use. So just giving a little bit of context to the background for each of those studies, and then we'll go into the method. But in terms of mental health, I think we've heard a lot about that today. So some individuals experiencing moderate to severe COVID-19 related mental health problems. And we haven't talked so much yet today about substance use, but there's lots of evidence coming in that at least some individuals were drinking more and consuming more substances like cannabis during the lockdown period. It seems that those with more distress were experiencing more substance-related increases in substance use. What about couples? Well, we do know during the time of COVID lockdown, couples were spending extended periods of time together in the home in isolation from others. So there's a lot of chance for them to be influencing one another's behavior. There is evidence that couples who reported more COVID-related stressors are experiencing more conflict within their relationship and having lower satisfaction with their relationships. We know that at the more extreme ends of conflict, that rates of incidents of intimate partner violence were increased during COVID, during the pandemic. And we also know from pre-pandemic research that conflict and alcohol problems tend to co-occur within romantic relationships. And there's evidence actually for a bi-directional relationship. So many of you are likely aware that substance use can lead to conflict and violence, but there's also evidence to show that there's an interesting relationship in the opposite direction where conflict can actually promote alcohol and other substance misuse through attempting to cope with the affect related to the conflict. Now, as I mentioned, when I'm talking about homeschooling, I'm talking about virtual learning, parents supporting virtual learning or putting on the schooling activities themselves. And this was a new role within parenting partnerships that parents had not been facing before. And of course, this new role can exacerbate the conflict that people are experiencing between their work and their family duties. And we know that work-family conflict in pre-pandemic times is related to alcohol use. So we were quite interested in how it would play out during the pandemic. And we do know that parents, compared to non-parents, are experiencing worse mental health since the onset of the pandemic relative to people that are not parenting children, including some of our work had shown that alcohol use increases were higher amongst parents than non-parents. So that brings us to the methods of our study, where we wanted to examine these issues in a dyadic context in people that were isolating together during the pandemic. So our participants were 758 romantic Canadian couples who are cohabiting during lockdown together. On average, they were 55 years old, predominantly white, and the majority were mixed gender couples, although in many of our analyses, we include everybody regardless of their sexual orientation when we can. And the survey was completed in June 2020, and they retrospectively reported on April, so shortly after the initiation of the lockdown, and that was true across provinces in Canada at that time. And then we had a subsample that were homeschooling children of 211 couples. We had validated measures of mental health, of romantic conflict, and of substance use, as well as motivations for alcohol and cannabis use. So the first study that I mentioned that I'll be going over looks at homeschooling effects on coping motivated substance use. So here we were comparing the couples that were homeschooling children and those that were not homeschooling children in terms of their mental health and their alcohol and cannabis coping motives for using those substances. And after controlling for differences between the groups, demographic differences between the groups, we found that the homeschooling couples had lower levels of optimism, greater role strain, as well as greater cannabis use and alcohol use to cope. Our second study focused in on the effects of homeschooling on drinking behavior and looked to see whether there were any differences according to gender. So our study aims were to examine now we're looking within those that were homeschooling, so that 211 subset of couples, about their mental health, about their alcohol frequency, quantity, and as well their peak drinkings. During that month of April, what was the most that they consumed in a single drinking occasion? Now, what we can see here is the number of hours that they spent homeschooling. We did see some after effects. So the more an individual was spending time homeschooling, the more they were experiencing anxiety, more depression, and more COVID-related traumatic and socioeconomic stress. And we did see some partner effects. So what we were seeing here is the more time they were spending homeschooling, the more their partner was drinking frequently, heavily, and having higher peak alcohol consumption. Now, when we broke that down by gender, we got some really interesting differences. So for mothers, the more time they were spending homeschooling, that was associated with partner effects. So the more the father was drinking, but we also saw that the more the mother was drinking herself, right? So her own homeschooling was having an effect on her drinking frequency, as well as her partners having crossover effects on her partner's drinking frequency. With the men, the more time they were spending homeschooling wasn't associated with their own drinking frequency, but it was associated with a lower drinking frequency amongst the mothers, as if the father taking more of an egalitarian role in homeschooling labor was associated with protective effects for the woman's drinking. And I should mention that women were homeschooling more on average than the men. Now we move over to romantic conflict and how it's related to coping motivated drinking in romantic couples. So in the entire sample, when we weren't separating by gender, we did find that the more the couple was reporting dyadic conflict, the more the individuals were each reporting greater coping motivated drinking. And the more that the individual was saying that I'm drinking to cope, the heavier their own consumption behavior. We were expecting also that we might, in this environment where the couples are really on top of one another, that we might see some of these crossover effects and see some partner effects of coping motives in your partner effects on the partner's drinking behavior. And we didn't see that in the overall analysis. However, when we broke things down by gender, this is where some really interesting effects emerged. So dyadic conflict was related to increases in both the woman's coping motives for drinking and the men's coping motives for drinking. For women, the more that they were motivated to drink to cope, the heavier their own consumption and the heavier their male partner's consumption. With men, the pattern was a little different. The more that they were motivated to drink to cope, the more heavily they were drinking themselves, yet the lighter their female partner was drinking. This is interesting, and it's been found with depression as well before, that women will modulate their drinking in response to their male partner's depressive symptoms. It may be that the women are modulating their drinking in order to give more room for the emotion work that women tend to do more within relationships than men. So maybe they're working to support their partner through the distress that they're experiencing. We don't know that for sure, but that's an interesting possibility. Now, I want to go into the discussion of our findings, the limitations, and the implications. So in terms of what we're seeing, we do see increases in substance use during lockdown from a variety of stressors, whether it be conflict within the partnership or the additional burden of homeschooling. It does look like parents are having difficulty managing the increased demands of homeschooling during the pandemic. At least they were back in that early period of April when it was first happening. And we do know that pandemic-related distress is more strongly related to drinking in women, and we're seeing this extend to another stressor, the stressor of homeschooling. And it does seem that more equitable division of homeschooling labor might have protective effects on alcohol use for women. We're also seeing that couples seem to be drinking to cope with romantic conflict during the pandemic, and that women, interestingly, might be modulating their drinking in response to their partner's distress. And although that looks like a protective effect, I think we also have to consider that there is data showing that IPV risk is highest when the man is drinking heavily and the woman's a light drinker. So there might be protective effects in one domain, yet risks in others. And our limitations, it was a cross-sectional design. We asked people to retrospectively report, from back to that period of the spring, but it was pretty close in time. There were some differences between the homeschooling and non-homeschooling couples that we had to control statistically. We didn't distinguish between voluntary and mandated homeschooling, although there are very few voluntary homeschoolers in our couples. And in fact, when we removed them, our results mainly stayed the same. We didn't examine the effects on children, but all of these limitations are overcome in another project that we've completed since the pandemic and that we're now analyzing the data. So we'll see, for example, the homeschooling effects on children's mental health. In terms of implications, it's suggesting that we really need to carefully weigh the costs and benefits of school closures. And I think we're seeing that that's happening in many jurisdictions and that there are many efforts being made to leave schools open as long as we can safely do so. Educational and psychological supports when we do need to close, particularly for women and mothers, really need to be provided. And that we really need to consider gender dyadic effects, and that these effects on mental health and on substance use aren't occurring in a vacuum, and we really need to take the social context into account. And the fact that we're seeing these partnered effects suggests that we really do need to be thinking about couple level interventions, not just individual interventions. I just want to acknowledge all the colleagues and students that have contributed to this work, as well as our funders. And then just to say thank you again for listening. And I'll turn things over now to our moderator, Dr. Allison Harvey, for her concluding comments.
Thank you so much, Dr. Stewart. And as we close our webinar today, I sincerely want to thank our speakers for sharing their important work. And although it may be hard to fathom, given the ongoing challenges of this pandemic, it seems highly likely this is not the last global pandemic or global public health crisis we will have. So I think these next months are a unique opportunity for us to collectively organize the lessons we've learned from psychological science to ensure that we have a voice and a seat at the table for documenting the needs, developing and testing treatments, for reorganizing systems of care, and for influencing policy. With that, I will hand back to Dr. DeSoto for some other closing remarks. Thank you, Andy.
Thank you so much, Dr. Harvey, and to all of our presenters for a fantastic symposium. I'd also like to thank my colleagues at APS who worked behind the scenes to help this event happen. Please do stay tuned to your emails to view a copy of the recording of this event. I'd also like to invite you to attend another event that's part of the APS COVID collaboration. That's on January 21st, 2022, starting at noon Eastern Time. It's titled Psychology, Biology, and COVID-19, What We Know and Why It Matters for Public Health. Please visit psychologicalscience.org/COVID initiative or stay tuned to your email to learn more and register for that event. Have a wonderful day.